Hi, and welcome to another episode of the Cancer Now What vodcast, brought to you by Arizona Center for Cancer Care. My name is Jenny, and I am very excited to have a conversation today with three physicians in our community who are dedicated to helping people go through a neuro-oncology cancer journey. We have Dr. Chris Biggs, who's a radiation oncologist with Arizona Center for Cancer Care. We have Dr. John Wanebo, who is a neurosurgeon with Barrow Brain and Spine. And we have Dr. Amir Azadi, who is a neuro-oncologist. Good afternoon, gentlemen. Thank you so much for being here today. Really appreciate you taking the time.
Glad to be here.
Of course.
Thank you.
Of course.
Thank you for having us.
Yes, of course. So May is Neuro-Oncology Awareness Month, right? We're talking brain cancer. And we always have the intent on this show of making sure that we bring in physicians in our community who can really articulate to our community what it means to be diagnosed with any type of cancer, specifically brain cancer, which is a pretty scary one when you're thinking about it. So I'm so appreciative that you could all be here, and I'm hoping we can just have a very open dialogue about what a patient goes through when they're diagnosed with brain cancer. So I will start with you, Dr. Biggs. Can you tell me a little bit about yourself? You're a radiation oncologist. How do you fit into the brain cancer treatment planning process?
Well, it's a whole ecosystem. And part of the way I explain it to patients is you're really going to see the three specialties, and we're all represented here today. Usually you see neurosurgery first, and then radiation oncology or radiation therapy is a very common component of treating both benign and malignant brain tumors. And then medical oncology or the use of drugs and chemotherapy is a very important adjunct to the treatment of these tumors as well. So almost inevitably, anybody who gets any kind of brain tumor or spinal cord tumor will see probably all three of us during the course of their treatment.
Got it.
So it's a very integrated team. From the standpoint of radiation oncology, which is what I do, is we use radiation beams, normally from a linear accelerator in one of our clinics here in town. And we focus those beams of radiation on the tumors and either try to kill them completely or delay the growth in the case of very malignant tumors. And it's quite effective. It works very well.
Very cool. We'll dig in more on that in just a minute. Awesome. Dr. Wanebo, neurosurgeon. So what is your role in this whole brain cancer thing? I'm assuming it has something to do with cutting.
I'm a nuts and bolts guy. Many patients who have a brain tumor present to a neurosurgeon because they because primarily they'll present with neurological symptoms, either weakness or numbness or speech trouble. And so they'll go to the emergency room or the regular physician for that, and they'll have an MRI of the brain obtained, and then we'll find a mass in the brain. And then we frequently get called to help evaluate and treat that. And frequently that ends up being, some sort of biopsy to figure out what this lesion is. Some of the patients, you have a reasonable idea if they have a prior history of cancer. That'd be one of the three types of brain tumors that we typically see, a metastatic tumor that came from somewhere else in the body and spread to the brain. And the other two types we see are intrinsic brain tumors that come from the brain tissue itself. Glioma is the classic one, is the glioblastoma. And then the third common type we see is a benign brain mass called a meningioma, which can give you symptoms and often needs surgery to resect. So, as Dr. Biggs alluded to, we work as a team, and typically we see these kind of patients on a intermittent basis and have repeat imaging and figure out what the next step is. But usually the first step is some sort of biopsy or resection. Biopsy just means you take out some of the tumor and test the tissue. Frequently, you'll go ahead and take out the whole lesion at the same time because it usually involves them being put to sleep and having a surgery.
Okay, so it sounds like if somebody has symptoms or their primary care doctor is worried about something, you're the first call. Or the ER, maybe even.
In many cases, that's
Okay.
the case.
Okay.
A patient will go to the emergency room or see their regular physician, and they'll have an MRI or a CAT scan, and then I'll get a call if
Okay.
I'm on call or
Okay.
taking those calls.
And then you decide at that point if you want to biopsy, take the whole thing out, what you want to do from there.
Right, yeah, evaluate the patient and the circumstances and figure out what the next step is.
Okay. And then sometimes after surgery, radiation can play a role, but sometimes medical oncology gets called. So Dr. Azadi, tell us when you are the person that comes into the picture and how do you medically treat these patients?
Yes, thank you for having me for this great conversation. So what I love about neuro-oncology, this is basically a field in oncology that requires multidisciplinary team approach. And I'm so grateful to be a part of this team. As I said, multidisciplinary meaning neurosurgery, radiation oncology, neuropathology, and neuroradiology. We are all involved in the care of the patients. And my role in this basically field is the chemotherapy part of treatment for many of these diseases involved in this category of basically pathology, including high-grade primary brain tumor or secondary brain tumors that travels from somewhere else in the body and metastasizes to the brain or spine.
Got it. So we've got the person who does whatever he can to cut it out. We've got the person who zaps whatever's left. And we've got the person who treats with medicine to help everything else, basically.
Right.
Is I mean, in layman's terms, like that's kind of what you guys are saying? Yeah? Did I miss anything?
Right.
No,
it doesn't sound like I went to medical school, does it? No.
No, I think it's a great description, and there's many kind of subtleties and gray areas in between. For example, there's occasionally tumors at the base of the skull or near the brainstem, for example, that can be treated with very high dose focused radiation called radiosurgery. And interestingly, it's one of the first fields where a neurosurgeon and a radiation oncologist learn to work literally side by side.
Wow.
At various radiosurgery types of machines. A machine called the Gamma Knife works quite well. Linear accelerator-based radiosurgery works very well. But we actually sit down and delineate the tumor volume and decide together what kind of dose that should receive. And it's a really interesting, fun collaboration because you get to learn, you see these three specialties, they're all three branches, very different branches of medicine. One is very surgical based, one is based in internal medicine, and myself is based in radiology. So we really spend a lot of time apart from each other during our training, and we're trained very differently. So to be able to come together, we kind of learn from each other. And it's really great for the patients because when do you have a bunch of doctors all sitting around for hours looking at your case and trying to figure out what the best way to treat you is? It tends to work out very well.
Okay.
Yeah.
So when you say that you're together, are you together in the operating room at the patient's bedside?
For radiosurgery, it has the word surgery in it,
Right.
but it's really just very high-dose focused radiation.
Okay.
It's not really an operating room, but it is a dosimetry room where we sit down and look at the images of the tumor, usually an MRI scan, maybe combined with a CT scan. And we say, where is this located? Is it close to something particularly delicate or particularly sensitive to radiation? For example, the optic nerve. You can have a meningioma, like Dr. Wanebo said, that might be very close to the optic nerve. You want to be quite careful about what dose that structure receives, so you both decide what you think is safe in that circumstance. So it's not really the operating room. Although we do see each other in the operating room because it's probably worth saying, there's a somewhat new treatment called the gamma tile, where the surgeon takes out a tumor, for example, and places radioactive seeds into the cavity where the tumor was to place, and that keeps the radiation very localized. And in that case, we do meet in the operating room for
That's
the placement of the
amazing.
tiles. Yeah.
Wow. So you guys really are working together, side by side.
That's right. In that case, we do for this treatment he mentioned called brachytherapy. It's kind of an old treatment, and in select patients, it makes sense, particularly patients who've had prior radiation, where you can give additional radiation at the time of a surgery.
Okay.
And to add what Dr. Biggs was discussing, what alluded to earlier, radiosurgery, those are lesions which you can treat with a bunch of beams focused on one spot in the brain where the tumor is. And sometimes those cases, or many times those cases, are done without a biopsy, where you don't need a new biopsy. You might know what the diagnosis is from another mechanism, or based on how it looks on the MRI or CAT scan. And so that is a type of a case where sometimes there's no biopsy, just radiation,
Okay.
and or chemotherapy.
Okay. So you're all talking about it, and you're all figuring out together what's best, because not all brain tumors are created equal, basically, is what I'm hearing, right?
Right, exactly. I mean, I would say, we are all together at the journey of treatment for these patients. So we might not be physically next to each other, but we all talk about the pathology and diagnosis and what's the best order of treatment. Sometimes we do radiation first, sometimes surgical resection might need to be done first, is sometimes all together, surgical resection plus radiation with gamma tile and chemo afterward, or sometimes we do chemo and then we change the order of the treatment. So we all basically all together in this journey for the patient to discuss and get the best options of treatment for the patients and get the best outcome.
It's a team sport.
Right.
It's a team sport. So let me ask you this, and I'll stay with you here, Dr. Azadi, if you don't mind.
Sure.
We see lots of different logos. We
Right.
all work in different offices, right? How do you communicate with one another? What are you texting each other? Are you calling each other on the phone? I know that I've heard tumor boards are a thing.
Right.
How do we make sure that we're staying in communication for the patients?
I mean, there are different ways that we do. I mean, as you mentioned, we do have the tumor boards. We have the tumor board discussion. We have the multidisciplinary clinic discussions. And always, if there is something in between these meetings that we have scheduled, we all call and talk to each other.
Okay. So you're just talking all the time,
Right.
basically, when you have patients that you share.
Yeah, many of these patients, I mentioned there's three basic types. The metastatic tumors are primary malignant brain tumors, and the meningiomas is a broad, rough description. But, they all get serial imaging on a regular basis. And the benign tumor, meningioma, is typically once a year, regardless of their treatment. But then the more aggressive tumors, either the metastatic tumors or the primary brain tumors, typically get imaging every 3 months. And when a patient gets a new MRI, we all essentially, the patient will make the rounds, between the three disciplines here, and we review their new MRI, see if there's any changes, and talk about what the potential options are. And typically, everything's always on the table, and you just figure out what makes most sense.
Okay, got it. Can you, Dr. Biggs, tell me a little bit about the difference between a benign and a malignant brain tumor? I think that, those are very powerful words that when people hear them, they definitely jump to conclusions one way or the other. Can you break that down for us a little bit?
Yeah, they are very, very different things. And benign brain tumors are not very common, but they're not exactly all that rare either. So a lot of people get them. There are some inheritable conditions that will increase the likelihood of you getting benign brain tumors or tumors along the surface of the brain. And we try to identify those people who have those conditions so that we can watch them very closely. But benign tumors come in a couple different varieties. The most common is a meningioma, which occurs usually on the surface of the brain in the layers of the membranes. And it's just, if it's very superficial and reasonably small, if the neurosurgeon can take it out without leaving any behind, then they're done. And really, that tumor rarely causes damage to the brain or to the nerves if it's in a kind of a common location. It's when they're in uncommon locations, or if they kind of silently grow a little bit too big, where you can start to see more difficulty for people. But the benign tumors are mostly curable, not all the time. Sometimes they are persistent. But most of the time they can be cured. The people's neurologic function usually comes back to normal or close to normal, and it's a great prognosis. So in the world of oncology, we love treating the benign tumors because it's usually good news. And then you get scans and you can tell people it all looks great and send them back home. So that's a really nice part of your day. The malignant brain tumors are a very different class, and they're an extremely difficult problem to solve. The most common one is a glioblastoma, as Dr. Wanebo alluded to, and we do our best to take as much out as you can and leave the person functional, and then they receive radiation and chemotherapy. And that's where I think I get a little jealous of Dr. Azadi, because the future of how to treat malignant tumors is really in the different biologic agents, different kind of chemotherapy agents that will come in the future and that are in the development line right now. So he's really the future. We've worked out radiation and surgery, which are very procedural type things, pretty well, but he's got all the creativity coming down the line.
Well, let's hear all about that, Dr. Azadi.
Right.
Tell us all the secrets.
Yeah, absolutely. I mean, specifically during the last 5 years, there has been a lot going on in the field of the neuro-oncology. In terms of the trials, there are hundreds of trials going on around the nation and in the world regarding the new types of treatment for high grade and some of the low grade brain tumor. Talking about the primary brain, I mean, there's a lot going on for secondary or brain metastases as well, but we are very excited to know, specifically after our grading system in 2021 changed the basically grading or basically categorizing these type of tumors based on the genetic of the brain or tumor cells, and how to treat them and how to basically face those type of tumor based on the genetics. And regarding to that advance in diagnosis, the targeted treatment and immunotherapy, clinical trials as a single agent or in combination going forward. And we are very excited to see more results regarding those clinical trials in the future.
Wow. So cool. And you're right here in Phoenix, and we can get it in our own backyard. That's amazing. Wonderful.
Exactly.
And I mean, I think that that's really important to mention too, because a lot of times people get, especially, the primary brain tumor, and they think I have to, go to Minnesota or New York or wherever, but they don't. We've got this treatment right here, and clinical trials are available here, and the cutting edge treatments are right here in Phoenix, which is amazing.
That's amazing. Exactly. I mean, for specifically GBM or glioblastoma, as Dr. Biggs and Dr. Wanebo mentioned, I mean, this is one of the disease that standard care, unfortunately, is not a very good outcome in terms of the survival. And in our guideline, clinical trial is actually superior to the standard care to be offered. So we are very excited to have clinical trials for those patients and get a better outcome for them.
That's amazing. Very excited to hear more about that for sure. So let me ask you this, Dr. Wanebo. What are some of the signs and symptoms that people have when they're suspected of having a brain tumor?
Typically it's a new neurological symptom, as in either numbness or weakness or speech trouble, sometimes vision trouble. Those would be the most common ones. The brain is like real estate. It's all about location, location, location. And so a small lesion or small tumor in a bad location can give you a lot of symptoms when it's small, whereas there are silent parts of the brain and not so good location, but a tumor would get very large to make you symptomatic in a good location. But as I mentioned, speech trouble, weakness or numbness or vision trouble would be the biggest symptoms that they might have. Sometimes headaches.
So-
new headaches that they had not had in the past.
Got it. So like a chronic migraine person, it's not likely a tumor. if
No,
they've had them
it would be
for
a
20
new
years.
a new
Yeah.
headache
Okay.
that had not been an issue before.
Got it. So when we're talking about cancer and when we talk about other types of cancers, we always talk about prevention. Are there things that we can do to prevent? I mean, is it like with lung cancer, don't smoke? Obviously, that's probably good advice for any type of cancer to avoid, but are there things specific to brain cancer?
I'll defer to my colleagues here in a second, but don't smoke, eat healthy, exercise, use sunscreen. Those are some of the key things to do.
Yeah, we're definitely getting the same message from all of the different oncology specialists, and it doesn't matter what the type of cancer is.
Yeah, I'm
It's
not
pretty much
sure
the same.
if Dr. Biggs or Azadi have any thoughts about cell phone use.
Oh, that's a great point.
I think
With
that's
AirPods.
still unclear.
Right, exactly. I
That's
mean,
a great point.
there has been some studies to basically focus in that specific matter if the cell phone and those basically sound waves has any impact in producing brain tumor or not. But I would say there is no clear cut or right answer, yes or no. But definitely, I would suggest just not overuse cell phone. But so far, we don't know exactly what's the right answer.
You are always reading studies, sir. Anything in the cell phone space you can share?
I find it a little entertaining because there's been so many trials that have conflicting results, and if it were a big effect, of course we would know it. So if there is an effect with cell phones, it's very small. But the reason I was saying is I'm a little amused is because I don't think people hold their cell phones to their ear anymore. They either put it on speakerphone or on their car or they're texting. And of course, if you're not holding it up to your head, then the risk is there is no risk.
What about the ear pods, though, or AirPods? What are they called? The things that people are putting directly in their ears? Could that be a thing?
The only kind of radiation that cell phones and those kinds of devices give off is radio waves, so microwaves actually, and they are capable of warming your tissues. So if there is a mechanism, it's not ionizing radiation. Ionizing radiation is what we give for treatment. It damages the DNA of cells, and it kills cancer cells quite effectively. But the type of radiation given off by cell phones is a much longer wavelength, and it doesn't hurt the DNA or the genetics of the cells at all. But it can increase blood flow because the temperature of the area will go up a little bit. So if there is any kind of very mild effect on the brain, it might be that area of the brain gets slightly warmer while your phone is held up to your ear. And does increased blood flow somehow correlate very weakly with potentially a growing cancer? Again, it's looking like probably not. But it seems like every 5 years another study comes out contradicting the last one.
Yes.
So if it
Kinda
were
like
big,
COVID.
we would know.
Yeah, for sure. Good. Well, that's super helpful. So I want to ask you all, based on your different specialties, the kind of side effects that patients can expect after treating with each of you. People, when we're talking about brain tumors, they're going to be thinking, am I going to have my verbal function when I'm done with this? Or am I going to lose my hair? Or, what are the effects going to be? So, Dr. Azadi, I'll start with you.
Right. So specifically in my field, in terms of the chemotherapy agents, we have the term of chemotherapy brain or chemo fog, as you name it. So patient might feel tired, fatigue, so not thinking clearly during the course of treatment, which usually after the treatment is done, they might have basically recovery from that, but it takes time. But definitely we have to basically focus, specifically ask the patient to make sure they are doing okay on the chemotherapy, they can tolerate the chemotherapy, they don't have basically side effects from the treatment that we get. Specifically in our field, neuro-oncology, we don't want to basically cause more damage or problem in terms of the cognitive function for the patient beside the tumor and other treatment modalities that they have from these issues.
Okay. And from surgery, brain surgery, what are some of the side effect concerns that patients have before they're in the OR with you?
Right. I mean, the biggest concern is that you could become worse neurologically. You know, not uncommonly, if a patient has a brain tumor that needs surgery, they'll have symptoms and may already have a neurological deficit, or as in being weak or having some trouble with their vision or speech. But we're fortunate these days that technology has made our lives and our work a lot more refined and easier, and being able to use MRI scans in surgery help us, you know, plan our trajectory to a tumor and working around it. And we try to resect a tumor safely, so maximum safe cytoreduction. So we always go into surgeries when we do them as to not cause any additional deficit, and then take out what we can safely. You know, ideally we can get everything. And for malignant tumors, that the more you get, the better in general. But you never want to compromise neurological function. And you know, we understand enough about the anatomy and have enough technology where we can do that in most cases, where we can keep people from getting worse neurologically.
Great.
So usually they can come in like they go out, or that's our goal. Not always, yeah. And we try to minimize shaving hair as well. So it just makes it a little nicer, especially for women.
So you just have like a little patch, and you can hide that with the rest of your hair based on where you cut.
Yeah, just a little linear incision.
Like a part.
Little part, essentially.
Oh, that's really good. I'm sure people appreciate that. Well done, sir. Dr. Biggs, what kind of side effects do people have from radiation when it comes to brain tumors?
Well, here's kind of a miraculous story, and that is that with the kind of the progress made with imaging and with computing power, with MRI scans, and with the way that our radiation machines are controlled, the radiation is given super precisely, like to within millimeters, and that's not the way it was, many years ago. In fact, for secondary brain tumors like metastases from lung cancer, melanoma, or something like that, we used to give radiation to the entire brain, and it would cause a lot of side effects for people. And I think, there's kind of a collective memory that radiation was not good for the brain. But with the new techniques, really, we give such precise radiation to those tumors that we actually rarely see a cognitive problem. You can, especially if there are a large number of tumors, or there are very specific cases where the tumors may have spread across the whole surface of the brain or throughout the brain, where we do need to treat a larger area. But even in that case, we've learned now, for example, how to spare the memory area called the hippocampus of the brain. And we give a type of radiation called hippocampal sparing radiation, which leaves the memory part of the brain alone and will make the cognitive abilities of the patient be much, much better afterwards. So it's part of why I went into radiation oncology when I did. That's when this explosion in technology was happening, and it's just been really great for patients in terms of the side effects.
Well, it sounds like there are definitely advances in all three of your fields that patients with this type of cancer can definitely access when they see you, and it sounds like we've made a lot of progress in the neuro-oncology space. So that's really encouraging.
And there's one thing we haven't really mentioned is molecular profiling. When we test these tumors, we do a molecular profile of the tissue, and it allows us to look for markers and see what particular treatments, especially for Dr. Azadi, that might work the best.
So it's like a targeted type of therapy.
It can be, yeah.
Exactly. I mean, we do test for the next gene sequencing of the tumor to know better regarding the basically molecular profiling of the tumor and how they behave, and that actually supports better diagnosis of the tumor and better and more precise treatment for each individual type of tumor. And as I said, I mean, there's a lot of clinical trials going on in neuro-oncology as we had advances in breast cancer, lung cancer, melanoma, and other fields of oncology. hopefully we can do better for the neuro-oncologist patient too. I mean, although there is some basically bumps on the road for us, including the blood-brain barrier, that we have difficulties to introduce those medication or targeted treatment or immunotherapy to CNS system, including brain and spine. But with all the advances in the science, now we have better methods of delivery of those medication, and hopefully we can get better response and better outcome in terms of treatment.
I'm glad you brought that up because a lot of people don't understand the blood-brain barrier. Can you explain a little bit about that and how that affects the effectiveness of the medicine?
Right. So basically, blood-brain barrier is basically a tool to protect our nervous system from anything outside to the brain. So actually, it protects our nervous system. But on the other hand, when we are trying to get medication to the nervous system, that makes it more difficult because the pores are very small. So some of these medications that we have available to treat the cancer, there are large molecules, so we cannot pass the blood-brain barrier and have a result. So, so that's basically is the problem to treat, or makes the treatment for brain tumor harder compared to other field of oncology.
Because the body is naturally protecting the brain from
Exactly.
letting bad things in.
Exactly.
Or anything in, if you
Right,
will.
right.
And you need to get in to kill the cancer.
So there is a lot of trials, including delivery of the drug or increase the basically penetration of the medication to the brain tissue by sono waves or thermal interstitial laser devices or other modalities to basically introduce the medication to the brain.
And are
tissue.
these relatively new ways of getting through the blood-brain barrier? I mean, has it been just, just sorry, you can't do it, like up until now?
No, they are in trials currently, but we are definitely hearing more advances and more basically progress in those fields.
So it sounds like we're getting to a game changer here for
Exactly.
brain cancer.
Exactly.
That's amazing. Well, I'm so excited to hear how you all work together to do that. So I have one more question for everybody. This is a question I ask everybody, just to get a little bit of humanity from our physicians. I'll start with you, Dr. Biggs. Tell me why you got into oncology, why radiation oncology, and why treating brain cancer is important to you.
Yeah, sometimes I tell my patients, I know this may sound a little weird, but I love treating people with brain tumors. They need my help, and I enjoy interacting with them. I find them to be interesting and engaging, and I just enjoy meeting them and going down the road with them and doing. Hopefully, if we can do something curative, that's great. If they can't, I like being there to help them out, and I enjoy it. I just don't know how else to say it. Some people might think that's a little weird, but you want a doctor who enjoys their patients, and I've always enjoyed that. So that's why I do what I do.
It's called compassion. That's the word for it. Thank you. Dr. Wanebo, why neurosurgery, and what is it about brain tumors that has interested you and gotten you into your field?
Well, I guess I was attracted to neurosurgery just because it's the brain is very fascinating, and how it works, and if there's a way to help people with brain issues, I thought that would be very exciting work. And my father was a surgical oncologist, and so I think I always admired his ability to help people with cancer. So I guess I put the two together a little bit.
That's amazing. Very good. Very good. And Dr. Azadi, neuro-oncology. Tell us why.
I mean, this is a fascinating field for me in terms of the field of oncology. So I think we are in the era that there's a lot of advances in terms of in the field of the neuro-oncology going on, and that's very exciting. And I'm grateful that I can be involved to help those patients, and hopefully we can fight this basically monster disease at some point.
Amazing. Wonderful. Well, all very good answers. Thank you. Dr. Azadi, Dr. Wanebo, Dr. Biggs, thank you all so much for being here. Thank you for joining us for another episode of the Arizona Center for Cancer Care Cancer Now What vodcast. If you would like more information on Dr. Azadi or Dr. Biggs, you can visit www.arizonaccc.com. If you'd like more information on Dr. Wanebo, you can visit barrowbrainandspine.org. Thanks, and we'll see you next time.